Everyone, and welcome to today's webcast on pediatric psoriasis. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer's speaker system by default. This means that if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, just select Use Telephone in the audio pane, and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation. We'll collect these and address as many as possible at the end. And before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as a voice for millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. For more information about these opportunities, you can log on to our website after today's presentation at www.psoriasis.org. Now I'd like to introduce our speaker, Dr. Laura Wineley. Dr. Wineley is originally from the Washington, D.C. area. She received her undergraduate degree from Harvard University. She completed the Medical Scientist Training Program at the University of Pennsylvania, where she was elected to the Alpha Omega Alpha Medical Honor Society. She completed general pediatric residency at the Children's Hospital of Philadelphia prior to her dermatology residency at the University of Pennsylvania. She subsequently completed fellowship training in pediatric dermatology at the Children's Hospital of Philadelphia. She joined the dermatology and pediatrics department at MUSC in 2014 as Director of Pediatric Dermatology. Dr. Wineley is a member of the American Academy of Dermatology, American Academy of Pediatrics, and the Society for Pediatric Dermatology, where she serves on the Patient and Practice Advocacy Committee. Her interests include general pediatric dermatology, with special interest in pediatric psoriasis, and vascular abnormalities and genetic skin disorders. Welcome, Dr. Wineley.
Thank you, Corinne, and thank you so much for inviting me to speak with everyone today about really one of my favorite topics. Today, we're going to aim to give a broad overview of pediatric psoriasis and just psoriasis in general. See if I'm able to advance the slides here. Excellent, here we go. So pediatric psoriasis versus adult psoriasis, while there are many overlapping features, we'll really try to highlight today how treating pediatric patients and the manifestations of diseases in those under 18 really can be different, particularly looking at important aspects of quality of life in children and adolescents. We will also start to talk a little bit about some treatment considerations, leaving hopefully ample time for questions. So as many people know, psoriasis is really a chronic disease that is most commonly seen in the skin. While we don't fully understand why some people get psoriasis, we do know that there's a very complex genetic background that interplays with some environmental triggers. The immune system plays key importance in the disease, and what happens is, because of immune system malfunction, your skin really overproduces the upper layers of the skin. And that leads to thickening and that thick scale that's over top of psoriasis. And these are what's called psoriatic plaques. What's really important to remember is psoriasis is not contagious. While it may run in families because of the genetic background, it's not something that can be passed to person. So to get on all the same page to define what we're talking about today, I want to go through really the different types of psoriasis. Psoriasis can vary a lot from person to person. It can also vary by age. So what psoriasis looks like when somebody is younger may be very different in them when they're older. The most common type of psoriasis is plaque psoriasis. These are larger areas, usually greater than 1 to 2 centimeters, and they have that thick white adherent scale. When you peel that scale off, which I certainly don't recommend, you can often see bleeding because it's so adherent to the skin below. One of the things that's a little bit different in children is that children get a lot more plaque psoriasis on the face. And scalp involvement is also very common. Guttate psoriasis refers to little drops of psoriasis that can be found anywhere on the body. Very typically starts on the trunk, so the abdomen and the back, and usually doesn't form as large areas as the plaque psoriasis. However, it's really common for people to have a combination of both the plaques and the guttate lesions, or somebody may start off with more guttate lesions and then develop into larger plaques. This type, guttate psoriasis, is much more common in children than it is in adults, and is the second most common type in kids. Inverse psoriasis can be found at all ages, but can vary by the area a little bit by age. So you can see in the corner here, this is a picture of what we call napkin psoriasis or diaper area psoriasis. So in babies, very young infants can get a lot of psoriasis in the occluded areas of the diaper, whereas in older kids, particularly adolescents, it may be found in the underarm or in the groin folds. Inverse psoriasis can be a little bit difficult to identify because you don't get that thick scale on top, and the lesions tend to be shiny and moist on the surface. And then rarer types of psoriasis can also be found in children. So one particular type is called pustular psoriasis, pictured here, where you have your typical red plaques, but you can see that they're studded with all these tiny little pustules. These pustules, again, they're not infectious. This is part of the psoriasis. This is not a sign of a bacterial infection, but is often misinterpreted as such. Erythrodermic psoriasis refers to when very large areas of the body are covered. This is the person who is red in greater than 80% of the body. This is a very severe type of psoriasis and can present either in one person with erythrodermic psoriasis, or sometimes when you have more mild psoriasis and you're exposed to a trigger, you can convert into erythrodermic psoriasis. This is can often be accompanied by very severe pain and severe itching, and sometimes even requires hospitalization for adequate treatment. One of the other types, kind of the forgotten types of psoriasis, is nail psoriasis. And you can have your nails, all 20 or less than 20 nails affected, and really with minimal psoriasis on the skin. This is very commonly misdiagnosed as a fungal infection and treated as such for months prior to the diagnosis of psoriasis. The nail psoriasis can really show up in many ways. So we can see pictures here of this thick ridging, of the crumbling of the ends of the nail. And then here, if you can see these little dots, this is called nail pitting, and then a separation of the nail from the bed underneath, which is called onycholysis. This can cause a lot of pain. It is also a real source of embarrassment because we really interact with the world with our hands, and your nails are really visible. And unfortunately, nail psoriasis is a very difficult type to treat. So all of these types of psoriasis, though, they really share a lot of the same challenges. We know that psoriasis can be itchy. It doesn't have to be itchy all the time, but oftentimes people complain about more severe itch at night or when they're stressed. There can be pain associated with cracks and fissuring, particularly if the skin really gets dried out, you can have bleeding. And then stinging and burning can both be a symptom of the psoriasis, and then unfortunately sometimes of the treatments that we use to treat it as well. Because of how visible psoriasis is and is often worn on very visible areas like the face or the exposed extremities, there is a lot of emotional stress and embarrassment that goes along with having psoriasis. And unfortunately, particularly for our youngest patients, it can be really difficult to manage this because they don't really understand what their symptoms are and they have problems even talking to us about them. So really, how many kids are affected with psoriasis? And I'll tell you, we don't fully know that number, partially because there's many kids that are not diagnosed and they may be treated for other conditions for a long time before they actually get the diagnosis of psoriasis. Very common, they may be told that they have fungal infections or eczema until they reach specialty care and somebody identifies it as psoriasis. However, we have estimates that it is common to have your onset of psoriasis before the age of 20. And really, psoriasis is a pretty equal opportunity player. It can happen from our youngest babies all the way to our oldest adults. And you can have really onset at any time in there. Many times psoriasis, as we've already talked about, does run in families, but the majority of patients, even children, do not have a family history or may have a remote family history, so not one of their parents that's affected. However, if a parent has the disease, about a little under a third of their children have a risk of getting psoriasis, and that really increases if both parents are affected with psoriasis. Unfortunately, understanding the genetics of this complex disease is really still in its infancy. So to date, we have over 20 genes that have been linked to the risk of developing psoriasis and have been passed down in families. However, the genes are much more common than people actually developing the disease. And there's many reasons this could be the case. So one is it may take multiple genes. So you might have to have multiple genes inherited from both mom and dad to come together to form psoriasis, or it could be the combination of having the genetics and then being exposed to something or having some other environmental trigger that we may not fully understand. And when you bring those together, then somebody gets psoriasis. In general, we do think about 3% of the population at all ages have it, although the genetics may be found more commonly than that. So really, what are some of the triggers? And I'll start this by saying is that unfortunately we don't have any way to prevent psoriasis. So if a parent is affected with psoriasis, we don't have a good way of saying if you can do this, we can prevent your child from getting it. We simply don't have that information right now. What we do know, particularly in kids, is one of the biggest triggers is infections. And this can really be all infections. So even the common cold, either a kid who already has psoriasis or somebody who's a new presentation may come down with a cold and then develop their psoriasis days to weeks later, or a flare of their psoriasis after their infection. One of the really big triggers in children is strep throat or strep skin infections. And very commonly we see in practice that kids are diagnosed with strep throat, and although they're treated, weeks later they have a severe new onset psoriasis. This is usually of the guttate type, although it can transform into plaque psoriasis. Now, some of these kids, when their strep is treated, their psoriasis will get better. But over 30% of people will have ongoing psoriasis even in the face of an adequately treated strep infection. Nonetheless, it's very important if you have a child with psoriasis to recognize the signs of strep throat and certainly bring them to medical attention to get it looked at if you think that may be what's going on, because it could be causing a flare of their psoriasis as well. Psoriasis can flare with other types of stress as well, so we do think that emotional stress plays a factor in addition to other physical illnesses, such as surgeries, other things that stress the body. And we don't really fully understand the impact of diet or weather on the skin. Some people may have a season they get worse in, so they might only have their psoriasis when the cold, dry weather. But in the summertime, they do a little bit better, and that might have to do with exposure to light, for instance. One of the things that we do definitely know is that psoriasis is really triggered by injury to the skin. And this is something called the Kebner phenomenon. So you can see here, this picture is a perfect example of these lines of psoriasis. These are all areas where the skin was scratched. And when you have even what seems like mild trauma in somebody who either has a predisposition or has active psoriasis, you get psoriasis in that area of skin trauma. It's important to note that this can also occur with a sunburn. So as we'll talk about later, light therapy, while it can be a really excellent treatment for psoriasis, if a child gets a severe sunburn while they have psoriasis, they can get a really severe flare of their disease. So we definitely recommend avoiding sunburn. Infections, as we already talked about, are a really common flare or new onset experience in children. And again, we really want to be fairly aggressive about at least paying attention to the onset of these illnesses and bringing kids to medical attention to see if they need appropriate treatment. The common cold, however, can lead to a flare, and unfortunately there's no treatments that we have to prevent that. So let's talk a little bit more about what the disease really means for kids. So some of the symptoms that the kids really cite as being severe and are a little bit different from kids to adults has to do with the involvement of the nails that we talked about, particularly because of the embarrassment that goes along with it. Very severe scalp involvement, including thick flakes, often necessitating that kids don't wear dark colors, or they oftentimes really are terrified about going out in places where their flakes could be seen. Diaper dermatitis is fairly specific to young infants who are still in diapers. And having the thick plaques on the extremities can be really very severe in children because of the visibility of those plaques. And as we already mentioned, the importance of the facial involvement, which is much more commonly seen in children. So to move on to our next talk about associations with psoriasis and particularly with treatments, I wanted to just do some definitions so that we were all on the same page. So to define psoriasis, we usually use the terms mild, moderate, and severe. And I really like this diagram here because it highlights that to have severe psoriasis, we're really only talking about more than 10% of the body. And if you are less than 10%, but that percentage of the body surface area is in locations that are more functionally significant or more visible, you could still have very severe psoriasis. So although you may just have the hands and the feet involved, that can prevent things like walking or being able to hold utensils and writing tools. And so therefore you would still be considered severe, although you may be less than 10%. In kids that have more severe psoriasis, we are beginning to understand that there are a lot of associations that we need to at least think about and to deal with if kids are at risk for these as well. So first of all, psoriatic arthritis, which is inflammation of the joints and can be involving a lot of joints, from larger joints such as the knee or smaller joints such as the fingers. This can occur either with active psoriasis on the skin or even in the absence of psoriasis. Psoriatic arthritis also correlates with nail psoriasis. So kids that have nail involvement do have a slightly increased risk of having joint involvement. The onset of psoriatic arthritis can also be at really any point in the disease. Some newer research, which is shown here, shows that children and adults, but particularly children, are more likely to be overweight. And going with that, they have increased risk of things such as diabetes, hypertension, and high cholesterol. There also seems to be a genetic link with Crohn's disease, so that either in the patient themselves or in the family, you also have people with both Crohn's and psoriasis. So let's talk a little bit more about these metabolic issues. So one really great new study looked at a large cohort of kids, over 400 kids in different countries. So in different countries, there's different percentage of children that are overweight. So this study was really nice by looking across countries and seeing that a high percentage, 40% of kids with psoriasis were overweight. And that in some studies also the being overweight correlated with having more severe psoriasis. This actually was shown particularly in the adult studies. In studies, the percentage of kids that are obese, so in the highest of the overweight classes, has ranged from 25% to one study that showed that 93% of children before the onset of psoriasis, so even before they were diagnosed, when they looked back at growth charts of kids that were diagnosed with psoriasis, really high percentage of kids were overweight even before the onset of psoriasis. Well, this doesn't really tell us certainly that obesity leads to more psoriasis. It could be the two have a complex interplay. I think it's really helpful to think about if your child is overweight and has psoriasis, really taking an active role with the help of your healthcare provider about looking at things that they can do in their diet or certainly with their activity level to try to combat this obesity. Psoriatic arthritis can occur in up to 30% of individuals with psoriasis. The number may be a little less in children, but we actually don't have a solid number in kids. And the onset of the psoriatic arthritis can really occur at any time. So you can get your arthritis before you actually have psoriasis on your skin, or you could have had psoriasis for many years and then start developing joint pain and stiffness and be then diagnosed with psoriatic arthritis. Going along with this, and we've alluded to it, and I'm sure everybody on the call really appreciates, is that having a chronic skin condition can really lead to a lot of problems with self-esteem, with relationships, and in some cases, frank depression. They wear their skin on the surface, and they really oftentimes have problems hiding areas of where their skin is affected. And so some kids really can withdraw from the social situations. They can have problems in school with bullying. And all of this can actually flare the psoriasis as well. So we really want to always think about what is the impact of the psoriasis on their quality of life. In fact, in some studies, they showed that psoriasis has an equal impact on quality of life as other chronic medical conditions such as diabetes. So it really is very high up there with the impact on quality of life. And it's something that always you should be talking about with your physician, because again, although they may not have body surface area that would put them into a severe category, if there's a real impact either emotionally, socially, or on quality of life, we do want to be more aggressive with treatments. Some of the areas that kids particularly have problems with are in areas that they can't stay covered up. So those tend to be having to do with physical education and team sports. A lot of kids I see will stop playing sports because they don't want to wear the uniforms that show up their psoriasis, or they may be having pain associated with it. It's always important for me to know, though, is this more emotional, or is there actually any physical pain that we might be missing undiagnosed arthritis as well that we really want to address to get them back into their activities. Swimming is a big deal. Many kids will not go into a bathing suit, and many people who care for a child with psoriasis have had that experience where somebody has approached them at a pool and they've asked what's wrong with their skin, or they've asked if they're contagious, or they've even been excluded from activities thinking that it is an infectious disease. It can be very helpful, particularly if that's an ongoing thing, to have your healthcare provider help educate or provide you with that information to educate people that this is not a contagious disease. So all of this being said, one of the real questions is, we know that it's important to support kids emotionally with psoriasis. Some of that can be really giving them just the support and giving them a chance to talk about their feelings. The other thing is finding a healthcare provider, a dermatologist, who the kid really trusts as well. So oftentimes, kids don't feel that people are really there to help them. And when they can find that person, it gives them hope and gives them somebody to talk about with their disease. There can be lots of education that can be done, and this varies dependent on the age of the child, but the National Psoriasis Foundation has some great programs or great information they can share with you about educating the school about psoriasis. And oftentimes kids, younger kids that are educated, they really handle it very well, and it can put your child in a position to kind of talk about something and be excited about it and see that their friends are interested. A lot of times some of the questions, while they seem negative, or they're just coming from a point of misinformation. Anything else that you can do to encourage positive self-image and confidence? And one of the things that I think can be really helpful here is to reach out to other people, either through the National Psoriasis Foundation or even through your dermatologist, to have your child connect with people that also have psoriasis, and particularly if they have a peer, because that oftentimes you can find somebody who has worked through some of these issues, and this can actually be helpful as the caregiver as well, because you're going to have emotional ties to taking care of your child and what they're feeling. Having somebody else to talk to can be really important. It is important, though, because we do know that depression is increased in kids with moderate to severe psoriasis, to look for signs of depression and certainly address them up front if they're severe. So I mentioned a few of them here, but really a change in their interest in activities, having difficulties motivating to do stuff, difficulties sleeping or oversleeping too much, and really having somebody who's not engaging in the normal activities or the normal relationships that they used to. But as I mentioned, one of the really important things is to find a healthcare provider who you share the common goal of helping your child. And this can be a huge deal for children, just to feel that they have a team on their side. Unfortunately, finding specific pediatric dermatologists can be difficult because, excuse me, because it is really an underserved specialty. But here are some resources. Certainly talking to your pediatrician. They may have had other patients who found good success with a certain provider before. In addition, the National Psoriasis Foundation can provide you information as well. Excuse me, one second. The Society for Pediatric Dermatology has a Find a Dermatologist feature, and these are all people that are very active in treating children. Before we get into the discussion about treatments, I want to mention this FDA conference that was held in March. And why this is important is that treatments for pediatric psoriasis have been very poor. But one of the things that came out of this meeting in March is the FDA really heard from the group that finding new treatments for pediatric psoriasis should become a priority. And this was very encouraging to me, and I really think this means that in the future we'll have more and more treatment options available. So first-line treatments still for either localized areas or more mild symptoms have to do with topical treatments. And there's really a wide range of topical treatments, only a few of which I've listed here. So the mainstay of treatments are topical steroids. Now, topical steroids, there are many products that are available. And most people with psoriasis have a drawer full of different creams and lotions and sprays and foams at home. And it's important to remember that not all topical steroids are created equal. So there's different strengths of steroids, and there's different strengths that are appropriate for different parts of your body. So certainly with topical steroids, you really need to follow the directions of your healthcare provider about what to use where, because you don't want to use something that is too strong for certain areas, such as the face or the diaper area. Topical calcineurin inhibitors, which have trade names of Protopic or Elidel, and the generic names of tacrolimus or pimecrolimus, are good and safe options for areas where long-term topical steroid use can lead to problems with skin thinning and atrophy, but oftentimes may not be as effective for really thick areas of psoriasis where strong topical steroids may be needed. There's a whole class of vitamin D analogs that can both be primary treatment, but can also be used in conjunction with topical steroids to limit the amount of topical steroids that you need. And all of these come in multiple preparations. So ointments, creams, lotions, foams, sprays, and oils, I've listed just a few. There's really a long kind of list of why you would use one over the other. For instance, it'd be really hard to put an ointment onto the scalp if you have thick hair, but using a solution in certain areas may burn. So if you get a certain product from your doctor and you're having a problem with it, like burning, like getting it to penetrate, or you don't like it, some kids also really don't like things that are greasy, or they have sort of aversions to different preparations. It's really a good opportunity to talk with your doctor and let them know, because there might be something else that's available that could work just as well and your child's going to like a lot better. One of the next lines of treatment for all types of psoriasis really is phototherapy. And one of the reasons that we really do like medical phototherapy is that it can be a very safe and effective treatment. So the problems with phototherapy is that it is a treatment they have to do a few times a week. And so if you don't have easy access to one, if you don't have one nearby, then just getting to treatments can have a huge impact on quality of life. And we certainly never want the treatment and getting to the treatment and the time away from other activities to be worse than dealing with the disease itself. There's a bunch of types of phototherapy. So the most commonly used is called narrow band UVB. And what this has is this is just a small part of light. So sunlight is made up all sorts of wavelengths, and this is really just a very narrow part of that, which has been shown to treat the skin the best without causing a lot of the side effects of skin cancer and premature aging. PUVA, which is a combination of oral or topical photosensitizer plus UVA therapy. This oftentimes is reserved for older kids and adults because it can be very difficult to tolerate in the young. And after hundreds of treatments, there may be an increased risk of skin cancer with this. But for limited use, we do think it's a very safe treatment as well. And there's another type of phototherapy which is called the excimer laser, which is essentially similar to narrowband phototherapy, but is in a laser head so that you don't have to go into the full box, which is pictured here. And this is really great if you have more concentrated areas or you have sort of sensitive areas that you would need to cover up in the light box, or if you have kids that can't really comply with standing in the phototherapy box or have a lot of anxiety about getting into the box. I should mention that you oftentimes can do phototherapy at home if you've had a good response in the office. However, insurance coverage for home phototherapy can be poor, but it's something to talk about with your doctor if your child has done really well on phototherapy and has something that they're going to need for a while. It may be worth getting a home light box to use for longer term. After we get out of the consideration of topicals and phototherapy, we're really moving into our next step, and this is for moderate to severe psoriasis. But again, somebody may have more limited area but have a really severe impact on them, such as hand and foot psoriasis. And here we do have a wide range of treatments available, but it's important to note that we have only in the last few months had our first biologic approved, so our first systemic medication approved for the treatment of psoriasis in children, and that was etanercept. We have a list of other things that we have used very traditionally, including methotrexate and cyclosporin. And this is when I get to this part, I have to say I have a lot of hope for the systemics and the biologic availability in the future. Over the past several years, the pool of systemic medications in adult patients has grown exponentially. And there's a lot of really excellent options that are now available. And I'm hoping now that we're going to move more into seeing some of those being tested and approved in children as well. All the systemics and biologics have oftentimes oral or injection. And it becomes really important here to consider, again, the giving of the medication or the side effects of the medication and how does that balance with the disease itself. Unfortunately, since most of these medications are used off-label, there can be difficulties with insurance coverage, but those are oftentimes things that we can work through in partnership with your doctor, your healthcare providers. So one of the questions that always comes up is, are biologics safe? Particularly when we're using them in young children. And the best safety data is for etanercept, which, as I mentioned, was approved for the use in pediatric psoriasis, ages 4 and up, just in the last several months, although we have a long history of using it in children prior to that. So infections was really the most common side effect that we saw in these studies, but there were very few serious infections. Most of these were upper respiratory tract infections and nasopharyngitis, which is a form of an upper respiratory tract infection. Very few that actually were thought to be either treatment-related or led to a stoppage of therapy because they were thought to be serious enough. Importantly, we have not yet seen an increased risk of malignancy with these medications, but that is something that we have monitored in all the studies as well. So when to think about using these biologic medications? So this is where you weigh the side effects versus the disease. And considering even the giving the medication, many kids have a lot of anxiety about injections or about the lab work that is associated with needing to these medications. But this is something oftentimes that you can work through, and there's good techniques and other types of things that we can do to minimize injection pain, to minimize the anxiety from the lab work. And that's something that's important to talk with your doctors about. And you also have to have found a doctor and that you can have these conversations with, that you can fully consider the side effects, and that your child can be involved in those conversations as well. I want to mention just last before we finish up here that dealing with both treatments, the effects of the disease, and getting through the stresses of school and through the educational requirements oftentimes really does require very specific intervention. So one of the things that you can do is, if you find that the care of the disease or the disease itself is really getting in the way of your child's education, you can talk with the school about these 504 plans. And this is a way to help the school both be aware and to designate services to kind of get you through what they need to so that they can meet their educational needs. Basically remove these barriers to learning. So just in conclusion, before we get to questions, psoriasis in kids and adults, while the disease is very similar, kids feel psoriasis very different. It affects them in different ways, and it's a very tough age to have a visible chronic condition. And unfortunately, because we don't really know what causes the disease, our treatments are really just kind of becoming more well thought out and more effective recently. And over the next few years, I do hope that we'll have a lot more options for treatment of pediatric psoriasis. Important to recognize psoriatic arthritis and to get appropriate treatment if you are having psoriatic arthritis. That can really change the way that we treat the disease. Then very importantly, be involved in the conversation. Find a dermatologist or pediatric dermatologist who's well-versed in psoriasis, who can treat children with psoriasis, and who is happy to have these conversations with you and answer your questions, because it's really an important partnership to have. And I'm happy to take any questions.
Thank you so much. Wonderful. Thank you so much, Dr. Wiley. We'll move into our question and answer session. So the first question here, do you have any recommendations for college-age pediatric patients for treatments when they're away from home?
So a lot of that depends on your child themselves. Some kids, by the time they're off to college, are very mature and have actually been doing a lot of their treatment plans by themselves. The other thing, too, is you really need to, before they go, you need to find the treating physician on campus or the treating physician that's going to be there for them, because they're not going to be able to get to their regular doctor. Many doctors will form a good relationship where you sort of have two doctors, the person managing at home and the person managing it when they're away. But really all the treatments that we've talked about can be excellent options for kids and teenagers, even if they're away.
Wonderful. The next question here. What are the risks and advantages of methotrexate in pediatric patients?
So methotrexate is our systemic medication that we've had the longest experience with. So prior to the approval of etanercept, even just a few months ago, methotrexate has really been the go-to medication. And that's because it is something we have vast experience with in children of all ages and a wide variety of diseases. Methotrexate may not be effective as some of the newer biologic agents, but that could be one child who takes methotrexate could have complete clearance, whereas another one could have no response. With methotrexate, fewer kids are going to have complete clearance, but if you're one of the ones that has that, that can be a great medication for you. The thing that's nice about it is an oral medication with not many side effects at the doses that we use it for psoriasis. We do long-term particularly have to follow lab work to make sure we're not getting any internal manifestations. But kids who've stayed on it for a long time and have had a good response can really tolerate it quite well.
Great. Next question here. Can Enbrel cause suicidal thoughts in children?
So the issue of depression and the biologics is really an unclear one at this point. That is something that has been looked at all of the studies, and certainly something that in chat groups is talked about a lot. We don't really know. What I would say is that unfortunately, when kids are severe enough to get on Enbrel or etanercept, even the generic name for it, they oftentimes are really at risk for depression anyway. So it really becomes a chicken and the egg problem. Is it the medication or is it their severe psoriasis? Hopefully, I've given you some tools to look for those signs and seek attention if you're worried about your child.
Perfect. All right, next question here. Is it safe to use narrowband UVB treatment in children as young as 2?
So certainly it could be safe to use. The problem in the younger kids with narrowband UVB is oftentimes they simply can't follow the directions that are needed during the treatment. So to use narrowband safely, you have to stand fairly still. You can't be kind of bouncing off the walls of the box. You have to keep goggles on, and those goggles oftentimes you can't see out of. And so children under the age of 3 in general, while some can do it, many just can't follow the rules. That is a situation, though, where there can be more targeted phototherapy methods. So sometimes they're hand wands, or even where the eczema laser, where you can get treatment with the child actually sitting in your lap. And so you can ensure that they're following along with the rules and they can stay with the parent, can be actually a better way of doing it in very young kids. We think, though, from the side effect standpoint, that it would be a safe treatment.
Great. This is kind of a two-part question. Is it worth getting a child allergy tested? Is there any published material showing success in treating psoriasis with diet?
So there has not been shown a link between a documented food allergy and psoriasis flares. Some people do find certain foods that seem to flare and trigger their psoriasis. I would caution against doing major elimination diets, though, and certainly if you have found something that seems to be a link between a food and a psoriasis flare, that you really talk with your doctor about that to be able to go after finding out if there is a true link before eliminating something that could be important to the child.
Great. What would be the best treatment for nail psoriasis in children?
So nail psoriasis really is our most difficult type of psoriasis to treat, and that really also depends on the age of the child. Oftentimes I'll start with topical treatment, so higher potency topical steroids or even topical retinoid medications that are applied around the nail. However, if you have a symptomatic nail psoriasis and you have an older child, one of the best treatments is intralesional steroids, where we actually do steroid injections into the part of the finger that makes the nail. Excuse me. This is very painful, so it does take an older child who's very motivated to sit through that, to want to go through those treatments. Some of our systemic medications can work for nail psoriasis as well, particularly the biologic medications tend to work a little bit better than methotrexate, although for the person who responds to methotrexate, that could work for your nails as well. Unfortunately, getting nail psoriasis better doesn't always mimic when you get your skin psoriasis better. So you could have a treatment that really works for the skin, but the nails may not improve.
Thank you. Next question here. Are there any studies showing a link of age of diagnosis to incidence of cardiovascular comorbidities?
So we don't have those studies yet. What we more know is that the psoriasis plus other risk factors. So psoriasis plus obesity, psoriasis plus family history. So the kind of combination of risk factors may be the highest risk when you put them all together, which is why thinking about things like activity and weight control can be important in young kids with psoriasis. Whether we'll have that data that says that if you've had psoriasis for a longer time, you're at higher risk of cardiovascular comorbidities later on, that may be information that comes out, but it's not been shown yet.
Next question here. What are the long-term effects of using clobetasol propionate?
So this really depends how you use it. So clobetasol is a very potent topical steroid, and oftentimes for thick psoriasis, we need to start with potent topical steroids. What's really important with our more potent steroids is to really use them only on affected skin. So this isn't the steroid that you want to put all over, although you may just have limited psoriasis. It also is particularly more of a problem if you were to put clobetasol in areas that it's not made to be used, such as the diaper area, in skin folds, or on the face. Where the skin is thinner and you're more at risk for having skin atrophy, one of the big things also, particularly in adolescents who overuse potent topical steroids, are they can get increased stretch marks. And this is really tough because particularly adolescent girls are really at risk for getting stretch marks anyway. And even adolescent boys get a lot of stretch marks when they go through their most rapid growth periods. Overusing potent topical steroids on skin that doesn't need it can increase that risk. So we really try to be careful about using it only as prescribed.
All right, thank you. Next question here. Is there any difference in treating African American children?
There are not many differences in treating them. Everything that we've talked about really applies to all types of skin. What I would say about African American children is the diagnosis often happens later. It can be a more difficult diagnosis to make, but once you get the diagnosis, all of these treatments apply. One of the issues with darker skin types is that there's more discoloration that can go along with the psoriasis. So even once you treat the psoriasis, you can be left with a white spot or a dark spot where the psoriasis was. And unfortunately, that can take a really long time to get better. And that's what we call post-inflammatory pigment alteration. And it's important to try to recognize the difference between active psoriasis and those post-inflammatory changes. So we're not actively treating areas that we just really need to give a little bit of time for the color to normalize.
And next question here. Can you recommend any alternative treatments for scalp psoriasis in children?
So scalp psoriasis really depends a lot on the thickness of the hair and the ability of medications to penetrate. So everything that we talked about can apply to scalp psoriasis. However, it's oftentimes very difficult to get the topical products when you have onto the scalp when you have really thick hair. So you can use a lot of descaling preparations. So there's combinations of shampoos. So some of those include tar-based shampoos or shampoos that contain the ingredient salicylic acid that can help to reduce the scale in the scalp, that then allows our topical medications to get better penetration into that scale. There's many medications that come in solutions or sprays that can penetrate a little bit better into the scalp as well. So it's something that you can specifically ask about because you can imagine if you had a big, thick, greasy ointment, it'd be a little bit hard to get down into the scalp. Light therapy can be difficult if you have thick hair, but for kids that have short hair or thinner hair, even there's some types of light treatments that can be really effective. For instance, there is a light wand that almost has like this comb to it, and you can treat areas of the scalp with that. That's just a little bit harder to find, but you can ask your doctor if they have that scalp wand. Eczema laser as well can be difficult to get into the hair, but if you can, that can be a very effective treatment. Most of our systemic medications work for the scalp just as well as they work for the rest of the body. One of the important things with scalp psoriasis, though, that I think is a little bit underappreciated is that the Kevner phenomenon, that phenomenon of injuring or otherwise damaging the skin, causing more psoriasis, that particularly comes important in the scalp because we do a lot of brushing, and actually you'll see kids do a lot of picking and itching at the scalps. Scalp is oftentimes one of the more itchy parts of the body with the psoriasis. So it's really important to minimize any type of physical trauma or any type of stress on the skin on the scalp, and that can actually help control the psoriasis better as well.
Great, thank you. Next question here. Are there any specific products or activities that children with psoriasis should stay away from?
It really depends on your child's response to those different activities. Certainly I don't like limiting anything up front for children because if they should, live their life just like normal, whether they have psoriasis or not. What's important to pay attention to, though, is if certain activities really flare their skin, to think about ways to prevent that. So, for instance, to give you some examples from real life, kids that play a lot of soccer, they get a lot of psoriasis can be a lot of psoriasis under their shin guards. Well, you got to think about some good barrier protection. That's just from the rubbing and the friction from there. That's something that we can deal with and something that your doctor can really help you deal with. Not letting the skin dry out is really important. So there's some activities that lead to more dryness and therefore more flaring of the skin with psoriasis. But to participate in those activities, you might just have to increase your moisturizer use. So, these are all really important things to help your kid work through and figure out what's important to them, and really to try to not let the psoriasis control their life, and have a doctor that will work with you to try to really problem solve some of these issues.
And next question here, are tanning booths okay to use in lieu of UVB light therapy?
So we really strongly recommend using tanning booths, and there's a number of reasons for that. So tanning booths, the commercially available tanning booths, they are not regulated. So when you go into the booth, you really don't have any idea what you're getting. They are not medical devices that are regulated by any governing body. So the problem then becomes the balance of the rays that come out of the tanning booth may not be effective for treating the psoriasis, but we do know that using a tanning booth even once or twice vastly increases the risk of skin cancer. So we really recommend that against those. And if you have used a tanning booth in the past, I do recommend that you let your doctor know, because we like to make sure then that you're not at risk for skin cancers in the future.
Wonderful. And we have time for one more question here. Are there any risks by treating topically and not systemically?
So I think we're going to have more answers to this in the future. Obviously, the treatment decisions, everybody has to be comfortable with. You have to be comfortable with it, your child has to be comfortable with it, and your doctor has to be comfortable with it. And that's usually a discussion to kind of reach that point where everybody's happy. What we don't know is that if we treat psoriasis more aggressively with systemic therapies, and again, we're talking about the moderate to severe psoriasis, do we then reduce the risk of some of the comorbidities in the future? That may be the case, and that is active studies that are going on. I don't want to hypothesize about that yet. I would say, however, that it is important to always consider psoriatic arthritis. So you can have very mild skin psoriasis that really wouldn't warrant any more than topical therapy, but it's important to make sure that there are no arthritis symptoms, because arthritis symptoms can lead to joint destruction. And while psoriatic arthritis doesn't always require systemic medications, you should at least have your child evaluated by an experienced rheumatologist to make sure that there's no joint damage going on, because that would really change our treatment approach if we're having any active joint damage.
Great. Well, thank you so much for sharing your expertise with us. And if anyone has additional questions or their questions were not answered, please contact our Patient Navigation Center by phone, email, live chat, or Skype. And before we adjourn, we wanted to announce that we are very excited about our upcoming National Volunteer Conference, which will be held this August 4th through 5th in Chicago, Illinois at the Swiss Hotel. And we'll have special programs for youth and teens, as well as special activities for parents. You can register today at psoriasis.org/conference or find out more by contacting our Navigation Center. Finally, I wanted to mention that a recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archives by visiting psoriasis.org/webcast. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. Thank you for joining us tonight, and have a lovely evening.